Yeah, good evening all and welcome. I am Sundeep Akula from NATCO team. So today, once again, with listening to the other episode of Respire, where we talk about lung cancer awareness one voice at a time. It's a joint initiative by NATCO and Voice of Healthcare. So when we talk about Respire, rising awareness to fight against the lung cancer. So lung cancer is one of the most commonest and also remains one of the leading cause in cancer related deaths. And also in India, there are a lot of misconceptions and gaps and also myths in understanding it. So it falls into the shadows of focus, and we also need an expertise to deliver it. So today, to deliver to show a light, and we have with us renowned medical oncologist Dr. Nitsh Garg from Sohana Hospital, Mohali, who makes us understand the vital aspects of lung cancer awareness. So welcome, sir. It's always pleasure to be you on the Respire platform, sir.
Thank you, Sandeep. Thank you inviting me. Thank you for inviting me here. And it is a privilege to aware my fellow countrymen and my people about this deadly disease, which we have been able to tackle with due diligence.
Yes. So coming to let us understand the burden of this, sir. So when you see the trends, how does it is increasing in incidence lung cancer, sir?
So if you ask me about the incidence of lung cancer, there has been certain shift because it we have seen that it has risen in non-smoker population also. Also, more of the females, sorry, more of the female patients are coming up with these cases. With the increase in tobacco and also the pollution, the chances are still increasing. So this has been a general shift from a smoking population to a non-smoking and a female population.
Okay, sir. And when you talk about the northern area, sir, because you are in the northern belt, so how is the incidence of this lung cancer, sir, particularly in your belt?
I believe it does not change in India with the geographical pattern, but yes, the prevalence because of the tobacco use is different in different areas. So there may be some changes because of that. Otherwise, and then there may be changes because of with the presentation, how the patients present and when they are diagnosed. Otherwise, if you ask me the percentage wise, yes, there are differences, but there is not a great difference throughout the country.
And what is the particular age of standardization getting diagnosed? Any median age, 35 to 40 or something?
So yes, definitely. Initially, we used to see elderly patients, old patients, but nowadays we are seeing younger patients who are coming with this kind of disease. And these patients, mind it, they are usually non-smokers. So that has been the shift which we have seen. And in these younger patients, non-smoking population, the disease tends to be aggressive.
Sir, you initially said that there is a shifting trends in smokers and non-smokers. Is it really impact? Is it creating impact on non-smokers also, sir?
Yes, definitely, because approximately I can say about 15 to 20% of my patient population, what I see in the OPD are non-smokers, females who have not smoked at any time during their lifetime, a younger patient who has not smoked any time. And this probably is because of the pollution. Then you can say the occupational hazard. Then the third factor which may be leading to this is the genetic makeup of a patient. Fourth will be the family background. So these are the usual factors which are involved in the patient population where we tackle the non-smoker individuals.
So there are four risk factors beyond the usage of tobacco.
You can say these are the four important ones.
Okay. And coming to the early diagnosis, sir, early detection, how does it happen? Any guidelines you follow for this lung cancer?
So definitely, see, there are few things when we talk about early detection. First of all, we have to understand what is the risk population or risk
Yes.
individual, or you can say high risk individuals. So those patients who are in the age, or those, sorry, not patients, basically those individuals who are in the age of 50 to 80 has smoked more than 20 years or more than 20 pack years. So this pack years is defined as one pack year per day for a year is equal to one pack year. So one packet should contain about 20 cigarettes. Unfortunately, BDs are unaccountable because we don't know what is the percentage tobacco content in those. They are handmade, or they are not weighed properly, that like what will be the tobacco content. So it is limited to the cigarettes. So that is how we find out. And then those individuals who have stopped or quit smoking for 15 years and still having some or the other small irritating factor, or they still want to get themselves evaluated, those can be included. Then the third point here will be the family history. Where the individuals have a family history of lung cancer, these turn out to be high risk cases. Then the fourth point will be the occupational cases. So, occupational chemical exposure also should be included in the high risk individuals. So, these are the high risk cases or high risk individuals which should be evaluated with a low dose low dose CT scan, which can be done annually. So this is the basic guideline which has been approved throughout the world. But unfortunately, when we talk about the guidelines, implementing the guidelines becomes difficult.
Okay, sir. So one point when you talking about this, if the person is continuously smoking for 15 years, addicted for smoking, suddenly if he stop, if he quits the smoking, so the lung
Right.
can be there will be any changes, sir? Because a lot of uh,
See, if we say that the patient has quit smoking and the lung is going to turn back to the original shape, it is not possible. Yes, there has been studies that if a or a person has quit smoking for more than 10 years, the lung activity, the lung parenchyma becomes almost equal to the normal individual who has not smoked throughout his or her life, but not as same as the
mm,
normal individual. So there is a difference. Yes, the chances of having lung cancer if a person has stopped or quit smoking for more than 10 years reduces to a greater extent, but the lung parenchyma does not become the same.
okay, so when you we were talking about diagnostic tools like low dose CT, is really accessible and affordable to the patients who are staying in tier 2, tier 3 cities.
So if you ask me about low dose CT screening in India, I believe it is a tough task to ask for, because the availability is very much limited. Then the issue comes with the technological advancement and the teaching program for this. So either the technical staff is not available, or the availability of low dose CT itself restricts it. So this is the most important hindrance for us to impose this as a screening tool. And the third point will be the cost effectiveness. So if it is not available or not per se available to a larger group of population, to cater a smaller group of population becomes costly.
And what are the general signs and symptoms of this lung cancer?
So usually general symptoms, patient come with a cough, history of long-standing cough with hemopsis. Hemopsis is blood in sputum. Then there can be history of shortness of breath. Then history of weight loss of and loss of appetite. These are the few important symptoms where the patient has a metastatic disease, means the disease has gone from the lungs to some other area of the body. There the patient can present with the symptoms of a metastatic disease also, like if the disease has gone to the bones, there can be some bony pains. If the disease has gone to the brain, there can be some seizure-like symptoms or stroke-like symptoms also.
Okay. So the when you are explaining the symptoms, we should not ignore all. That is what.
Definitely, definitely.
So, okay. Okay, sir. Coming to the treatment and innovations, how does the treatment landscape has changed in last decade, sir, in lung cancer patient to treat a lung cancer
Uh,
patient?
Sundeep, I'll say not in the last decade because the things have evolved drastically. So, if you
Okay.
ask me about 25 years back, the treatment would have been either the best supportive care. If a patient has been diagnosed with a stage 4 lung cancer, we used to tell the patient family, please take the patient home, just give them tender love and care, nothing else. Then came the role of chemotherapy. So after 2004, there has been a bombardment of drugs which has changed our perspective. Even it has made our task difficult to treat these patients with precision. So from 2000, you can say to 2025, where the survival was 6 months to 8 months. Now we are looking at a survival somewhere around 2.5 to 3 years in a stage 4 disease, and some cases even longer than that. In a stage 4 disease, this is what I'm talking about. So, evolution has been a great part of this, and this is basically because of the advancement in target therapies and immunotherapies.
And sir, when you talk about these targeted therapies and immunotherapies, they are really affordable and accessible to the patients, sir, cost wise.
Yes. So few of the targeted therapies which commonly we see, like I can give an example. What we see commonly is a endo epidermal growth factor receptor. This is a receptor which is seen on the lung cancer. Just give me a moment.
Yeah, please.
So epidermal growth factor receptor, this is a receptor which is present on the lung cancer cells. So in 2004, this drug was made available. It was labeled named erlotinib, and then came geftinib. So they came almost at the same time. They were very costly that time. So now with the branded generics or the generics available, they are very cheap, actually affordable, and I can say not more than 5 to 6,000 per month as a therapy. And this is one of the commonest mutations what we see in lung cancer. If I talk about the rare mutations drugs are available. Yes, they're not as affordable as this, but the public or and the public private partnership has made these available with a very much good support programs for the patient. So where they do some cost sharing and make these drugs available, the rarer drugs, very cheap. Like I can give you an example of immunotherapy drugs where about 2 years back they were costing 34 to 40 lakhs in a year. Now we are limited to the cost, and the cost is limited to somewhere around 8 to 12 lakh in a year. So with this much of reduction in the cost, it has become affordable to at least uh, affordable to the middle income group also.
Okay, sir. Sir, you talked about treatment. So before coming to you, the patient, what could be the psychological impact of that patient, sir? Because cancer itself is a. So how does
So
you?
yeah, so psychological impact is very much there, and it is not limited only to the patient, but yes, to the family also. So patient will be feeling distressed, anxious. Because of this anxiety and distress, the quality of life is going to deteriorate further. Along with this, there will be stress of the financial impact on the family. There will be the stress of the social stigmas associated to this. And then there will be the stress of the treatment itself. the side effects of the treatment, and also the survival. So all of this, the patient and the family both are stressed. They will or will not be able to take that diagnosis is very important. So we have to make them very clear, make them comfortable, at least let them talk it out that these are the issues what they have, and so that a person or a cancer physician can plan a proper precision or a targetable, possible targetable treatment for that patient.
So you said that in late stage disease, the survival rate is around 2 years, but still there is lot of social stigma exists, sir. Lung cancer. So why it is happening, sir?
Yes.
Any
See, as I discussed with you just now, so social stigma is going to be there. It is there with almost all the cancers. Specifically for lung cancer, when we talk to our patient, we tell them that smoking is the commonest risk factor. And a person who has smoked for almost 50, 60 years, they think in a different direction. They think they self-blame themselves. They have a uh, they have that anxiety that they have done some mistake throughout their life and now they are going to suffer. And all along with this, the fundings, the research, those kind of things are reduced when it is associated with the use of recreational tobacco. So, and also the support programs. So when we talk about support programs, though there are a lot of support programs, the public-private partnership has given us, but still those becomes limited. So in case you talk about some other disease, there will be even better research and even better support programs. So though these are the kind of stigmas which are there, but yes, main stigma which is there is the self-blame, and because of that self-blame, it may also delay the diagnosis. So feelings of guilt and self-blame harms it.
sir, when you talk about this private policies and government insurance, a lot of insurance are available. But what do you think, in your way, what should the policymakers bring differently to reduce this lung cancer burden in India?
So see, first of all is the cessation of tobacco. So until unless the government is putting a curb on the tobacco use, this is not going to go. So, and I'm not very sure if we are working on that or not. Yes, it is a part of our revenue. It is difficult. So then the second thing will be making people, making the public healthcare practitioners, nurses aware that these could be the symptoms and signs of lung cancer, and these patients should have a better and easier referral program so that they can be referred to a super specialist or a specialist at the earliest. Then comes the financial help. So they can give some financial, like the insurance should include these immunotherapies. The government should start including the immunotherapy drugs in the government insurance programs or the government assistance schemes where they can help these patients to get a better accessible treatment. So providing a better uh, financial stability to the patient and a better accessible treatment to the patient.
Okay. And coming to this, anyways, this day after tomorrow is no tobacco day. So, what could be a
Correct.
strong message to public or our viewers? You, uh,
So, so first of all, I will say tobacco use should be limited as much as possible, because one of the most important risk factor in oncology, not only limiting to lung cancer or a urinary bladder cancer, tobacco has been a risk factor everywhere. So limit, if not, if not, limit, I think is a wrong word. It is stop it or quit it as soon as you understand about it. So that is the most important thing. And other thing to understand is any kind of this disease is not the same for every patient. It may be different to patient. So we should not be scared of it. And if we are not scared of it, we will be able to tackle it with care, and the patient's life is going to better. So quality, making the quality of life better becomes very important.
Thank you, sir. You have enlightened us with the treatment evolution, signs and symptoms, and also the limited usage of tobacco. So thanks for enlightening us with these points, sir, and also giving a vital aspects of lung cancer, where to work and where not to use everything. Thank you very much, sir.
Thank you.
And
Thank you.
thank you, Voice of Healthcare, for supporting this Respire platform. Once again, the backend team also. Thank you very much, sir. Thank you, doctor. And
Thank you.
sir, we thank you, sir.